Morning class. So today we're going over Chapter 32, Environmental Emergencies. Trauma applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. Environmental emergencies, recognition and management of submersion incidents, temperature-related illness, pathophysiology assessment and management of near drowning, temperature-related illness, bites and envenomations. Dysbarism, high altitude, diving injuries, electrical injury, radiation exposure. Introduction. Medical emergencies can result from environmental factors. Certain populations are at a higher risk. Children, older people, people with chronic illnesses, young adults who overexert themselves. Environmental emergencies include heat and cold related emergencies, water emergencies, pressure related injuries, injuries caused by lightning, envenomation. Factors affecting exposure. Physical condition. Patients who are ill or in poor physical condition will not tolerate extreme temperatures well. Age. Infants, children, older adults are more likely to experience temperature-related illness. Nutrition and hydration. A lack of food or water will aggravate hot or cold stress. Alcohol will change the body's ability to regulate temperature. Environmental conditions. Conditions that can complicate environmental situations. Air temperature, humidity level, Extremes in temperature and humidity are not needed to produce injuries. Most hypothermia occurs at temperatures between 30 degrees Fahrenheit and 50 degrees Fahrenheit. Most heat stroke occurs when the temperature is 80 degrees Fahrenheit and the humidity is 80%. Examine the environmental temperature of your patient. So remember, always looking for clues, always even going into private homes, especially older populations, because they don't regulate heat very well or regulate the cold, and so they'll have the heater on, will be bundled up with a lot of blankets, and they might be suffering from heat emergencies when it's 60 degrees out. So be aware of your surroundings. Cold exposure may cause injury to feet, hands, ears, nose, whole body, hypothermia. These are 5 ways the body can lose heat. Conduction, direct transfer of heat from a part of the body to a colder object by direct contact. Heat can also be gained if the substance being touched is warm. Convection, transfer of heat to circulating air when cool air moves across the body. Evaporation, conversion of any liquid to a gas, natural mechanism by which sweating cools the body. Radiation, transfer of heat by radiant energy, heat loss caused when a person stands in a cold room. Respiration, loss of body heat during normal breathing. Warm air in the lungs is exhaled into the atmosphere and cooler air is inhaled. If air temperature is above body temperature, an individual can gain heat. The rate and amount of heat loss or gain by the body can be modified in 3 ways: increase or decrease in heat production, move to an area where heat loss can be decreased or increased, wear the appropriate clothing for the environment. Hypothermia. Core temperature falls below 95 degrees Fahrenheit or 35 degrees Celsius. Body loses the ability to regulate its temperature and generate body heat. Eventually, key organs such as the heart begin to slow down and mental status deteriorates. Can lead to death. Air temperature does not have to be below freezing for it to occur. It can develop quickly or gradually. People at risk, homeless people and those whose homes lack heating. Swimmers, geriatric, pediatric, and ill individuals. Okay, signs and symptoms become more severe as the core temperature falls, progresses through 4 stages. And we have a little chart over here. Okay, assess general temperature. Pull back your gloves and place the hand on the hand and your patient's abdomen. Normally, I feel the back of my hand on the patient's forehead. Does the patient feel warm? Especially for seizures as well. Febrile seizures, when kids have seizures because their temperature is too high, they're gonna feel hot to the touch all over, and you don't even have to pull your glove back. You're gonna feel it right through the glove. So it's not really necessary to pull your glove off. Mild hypothermia occurs when the core temperature is between 90 degrees Fahrenheit and 95. Patient is usually alert and shivering. Pulse rate and respirations are rapid. Skin may appear red, pale, or cyanotic. More severe hypothermia occurs when the core temperature is less than 90 degrees. Shivering stops, muscular activity decreases. As core temperature drops to 85, patient becomes lethargic and stops fighting the cold. May show impaired judgment. If body temperature is 80 degrees Fahrenheit or less, pulse becomes slower and weaker. Cardiac dysrhythmias may occur. Patient may appear dead or in a coma. Never assume a cold pulseless patient is dead. So as a general rule, patients are dead until they're warm and dead. So never assume a cold pulseless patient is dead. Local cold injuries. Most injuries from cold are confined to exposed parts of the body, extremities, especially feet and hands, ears, nose, and face. So we got a little frostbite in the fingers and toes, and then also the nose as well. Important factors in determining the severity of a local cold injury: duration of the exposure, temperature to which the body part was exposed, wind velocity during exposure. I'm sure you guys have all heard of wind chill factor. It could only be 50 degrees out, but with the wind blowing, could drop that temperature down. You should also investigate underlying factors: exposure to wet conditions, inadequate insulation from cold or wind, restricted circulation from tight clothing or shoes, or circulatory disease, fatigue, poor nutrition. Alcohol or drug abuse, hypothermia, diabetes, cardiovascular disease, age. Frostnip and immersion foot. Frostnip, after prolonged exposure to the cold, skin may freeze while deeper tissues are unaffected. Usually affects the ears, nose, and fingers. Usually not painful, so the patient often is unaware that a cold injury has occurred. Immersion foot occurs after prolonged exposure to cold water, common in hikers and hunters. Signs and symptoms: skin is pale and cold to the touch. Normal color does not return after palpation of the skin. The skin of the foot may be wrinkled but can also remain soft. Patient reports loss of feeling and sensation in the injured area. Frostbite, most serious local cold injury because the tissues are actually frozen. Gangrene requires surgical removal of dead tissue. Yeah, you guys have a nice little picture of gangrene right there. So signs and symptoms: most frostbitten parts are hard and waxy. The injured part feels firm to frozen as you gently touch it. Blisters and swelling may be present. In light-skinned individuals with the deep injury, the skin may appear red with purple and white, or mottled and cyanotic. The depth of skin damage will vary. White with superficial frostbite, only the skin is frozen. With deep frostbite, deeper tissues are frozen. You may not be able to tell superficial from deep frostbite in the field. So, always encourage medical attention whenever you have a cold injury. Scene size up, scene safety. Note the environmental conditions. Know what you're walking into. What's the temperature outside? Is it really hot? Is it really cold? Ensure that the scene is safe for you and other responders. Identify safety hazards such as icy roads, mud, or wet grass. Use appropriate standard precautions. Consider the number of patients. Summon additional help as quickly as possible. Mechanism, injury, or nature of illness. Look for indicators of the MOI. Primary assessment. Form a general impression. Perform a rapid scan. Scan the scene when you come on. If life threat exists, treat it. Check temperature. Evaluate mental status using the AVPU scale. An altered mental status can be affected by the intensity of the cold injury. If the patient is in cardiac arrest, begin compressions, airway, and breathing. Ensure that the patient has an adequate airway and is breathing. Warm, humidified oxygen helps warm the patient from the inside out. Circulation: palpate for a crowded pulse and wait for up to 60 seconds to decide if that patient is pulseless. So, when a patient gets submerged in water, we have what's called a mammalian diving reflex. And what this does is it actually slows our breathing down. This actually slows our heart rate down if we get submerged in cold water. So this is why we wait a little bit longer to see if we get a pulse, because everything in the body slows down. So the AHA recommends that CPR be started on a patient who has no detectable pulse or breathing. Perfusion will be compromised, bleeding may be difficult to find. Transport decision complications can include cardiac dysrhythmias and blood clotting abnormalities. All patients with hypothermia require immediate transport. Rough handling of a hypothermic patient may cause a cold, slow, and weak heart to defibrillate. So be very careful when you guys are moving cold patients. History taken. Investigate the chief complaint. Obtain a medical history. Be alert for injury-specific signs, symptoms, and any pertinent negatives. Sample history. Find out how long your patient has been exposed to the cold environment. Exposures may be short or prolonged. Secondary assessment. Physical examinations focus on the severity of hypothermia. Assess the areas of the body directly affected by cold exposure. Assess the degree and extent of damage. Vital signs may be altered by the effects of hypothermia and can be an indicator of its severity. Respirations may be slow and shallow. Low blood pressure and a slow pulse indicates moderate to severe hypothermia. Evaluate for changes in mental status. Monitoring devices. Determine a core body temperature using a hypothermia thermometer. Pulse oximetry will often be inaccurate. Reassessment. Repeat the primary assessment. Reassess vital signs in the chief complaint. Monitor the patient's level of consciousness and vital signs. Rewarming can lead to cardiac dysrhythmias. Interventions. Review all treatments that have been performed. Reassess oxygen delivery. Remove any wet or frozen clothing. So when you remove a patient from an environment, make sure to remove all their clothing. In either heat, you want to take off all their clothing. Make sure cool them down. And then if you remove somebody who's drowned or is hypothermic and they're still in clothes and they're wet, you want to take off all that clothing because that's conducting the cold temperature to their body. So take off all that wet clothing. Communicate all the information you have gathered to the receiving facility. Patient's physical status, conditions at the scene, any changes in the patient's mental status during treatment and transport. General management of cold emergencies. Move the patient from the cold environment. Remove any wet clothing. Place dry blankets over and under the patient. So look, this patient looks like they don't have any clothing on. So what the EMT did was probably cut off all the cold clothing, take it off the patient, and then put some warm blankets on them. And then also have a humidified oxygen going to help warm up the patient. If available, give the patient warm humidified oxygen. Handle the patient gently. Do not massage the extremities. Do not allow the patient to eat or use any stimulants. So when we talk about do not massage extremities, people want to massage the arms, the feet, see if they kind of get the blood flowing a little bit more. What's going to happen is you're going to send that cold blood and it's going to go all the way to the heart, and it might throw the heart into a lethal rhythm. So we want to warm the core of the body and not send that cold blood from the extremities back to the core. Mild hypothermia. Patient is alert, shivering, and responds appropriately. Place the patient in a warm environment and remove wet clothing. Apply heat packs or hot water bottles to the groin, axillary, and cervical regions. Give warm fluids by mouth. Moderate severe hypothermia. Do not try to actively rewarm the patient. The goal is to prevent further heat loss. Remove the patient from the cold environment. Remove wet clothing. Cover with a blanket and transport. Emergency care of local cold injuries. Remove the patient from further exposure to the cold. Handle the injured part gently and protect it from further injury. Remove any wet or restricting clothing over the injured part. Transport will be delayed. Consider active rewarming. With Frostnip, contact with a warm object may be all that is needed. With Immersion in foot, remove wet shoes, boots, and socks and rewarm the foot gradually. With a late or deep cold injury, do not apply heat or rewarm the part. Never rub or massage injured tissues. Rewarming in the field. Immerse the frostbitten part in water between 102 degrees Fahrenheit and 104. Dress the area with dry, sterile dressings. If blisters have formed, do not break them. Never attempt rewarming if there is any chance that the part may freeze again. Cold exposure in you. You're at risk for hypothermia if you work in a cold environment. Cold whether search and rescue is possible in your area, you need survival training, precautionary tips, wear appropriate clothing. Heat exposure. In a hot environment, the body tries to rid itself of excess heat. Sweating and evaporation of the sweat, dilation of skin blood vessels, removal of clothing, and relocation to a cooler environment. Hypothermia is a core temperature of 101 Fahrenheit or higher. Risk factors of heat illness: high air temperature reduces radiation, high humidity reduces evaporation, lack of acclimation to the heat, vigorous exercise, loss of fluid, and electrolytes. Persons at greatest risk for heat illnesses are children, especially newborns and infants, geriatric patients, patients with heart disease, COPD, diabetes, dehydration, obesity, patients with limited mobility. Heat cramps, painful muscle spasms that occur after vigorous exercise, do not occur only when it is hot outdoors. Exact cause is not well understood. Usually occur in the leg or abdominal muscles, so I'm sure you guys have had cramps before. They suck. You just have to kind of stretch it out, drink some fluids, get some electrolytes back in you. Heat exhaustion, most common illness caused by heat. Causes heat exposure, stress, fatigue, hypovolemia as a result of loss of water and electrolytes. Signs and symptoms: dizziness, weakness, or syncope, muscle cramping, onset while working hard or exercising in a hot, humid, or poorly ventilated environment, and sweating heavily. Onset even at rest in the older and infant age groups. Cold, clammy skin with ashen pallor, dry tongue and thirst, normal vital signs, normal, slightly elevated body temperature. Heat stroke, least common but most serious illness caused by heat exposure, occurs when the body is subjected to more heat than it can handle and normal mechanisms are overwhelmed. Untreated heat stroke always results in death. Typical onset situations: during vigorous physical activity, outdoors or in a closed, poorly ventilated, humid space, during heat waves without sufficient air conditioning or poor ventilation, children left unattended in a locked car on a hot day. So remember, ask the patient if they've done any vigorous physical activity. It may not be very apparent. Ask them if they've drank fluids that day. Ask them if they've had anything to eat. All questions you guys should be asking for certain patients. Signs and symptoms: hot, dry, flushed skin. Skin may be moist or wet due to exertion by the patient. Quickly rising body temperature, falling level of consciousness, change in behavior, unresponsiveness. Seizures: strong, rapid pulse at first, becoming weaker with falling blood pressure, increasing respiratory rate, lack of perspiration. Scene size up, scene safety, perform an environmental assessment. The heat emergency may be secondary to a medical or trauma emergency. Consider calling ALS. Look for indicators of MI. Remember, when you're walking on scene, you're looking around for any clues that could tell you what's going on. There might not be anybody there to answer your questions. Patient might be unconscious, might not be able to answer your questions. So look around, see if you find any clues as to why you were called. If the patient is immersed in a cold water immersion bath, monitor the patient and assist as necessary. Protect yourself from heat and stay hydrated. This also applies to you guys, especially when you're working. You guys need to stay hydrated, especially on hot days. Our air conditioning might not work in the ambulance. So use appropriate standard precautions, including gloves and eye protection. Primary assessment: form a general impression, observe how the patient interacts with you in the environment, introduce yourself and ask about the chief complaint, perform a rapid scan and avoid tunnel vision, assess mental status using AVPU. Remember, every call, try and avoid tunnel vision. Don't get caught up and think one thing's wrong with the patient and just go that route. You're always looking to see if there's anything more. Airway and breathing: unless the patient is unresponsive, the airway should be patent. Nausea and vomiting may occur. Position the patient to protect the airway. Consider C-spine. If unresponsive, insert an airway and provide bag valve mask ventilations. Circulation, if adequate, assess for perfusion and bleeding. Assess the patient's skin condition. Treat for shock. And this little table over here shows you skin condition and what it might indicate. So moist, pale, cool skin, excessive fluid loss and salt loss. Hot, dry skin, body's unable to regulate core temperature. Hot, moist skin, body's unable to regulate core temperature again. Investigate the chief complaint. Be alert for injury-specific signs and symptoms. Absence of perspiration, decreased level of consciousness, confusion, muscle cramping, nausea, and vomiting. Sample history. Note any activities, conditions, or medications. Inadequate oral intake. Diuretics, medications. Determine exposure to heat and humidity and activities prior to onset. Physical examinations. Assess the patient for muscle cramps or confusion. Examine the patient's mental status and vital signs. Pay special attention to skin temperature, turgor, and level of moisture. Perform a careful neurologic exam. Vital signs. Patients who are hypothermic will be tachycardic and tachypneic. Falling blood pressure indicates the patient is going into shock. And heat exhaustion. The skin temperature may be normal or cool and clammy. And heat stroke, the skin is hot. Reassessment. Watch for deterioration. The patients with symptoms of heat stroke should be transported immediately. Monitor vital signs at least every 5 minutes. Evaluate the effectiveness of interventions. Be careful not to overcool a patient. Communication, documentation. Inform the staff at the receiving facility early on that your patient is experiencing a heat stroke. Additional resources may be required. Document environmental conditions and the activities the patient was performing prior to onset. Management of heat emergencies. Heat cramps. Remove the patient from the hot environment and loosen clothing. Administer high flow oxygen if needed. Rest the crampy muscles. Replace fluids by mouth. Cool the patient with water, spray, or mist. So remember, you're going to remove the patient from the hot environment. The patient's outside. The patient might be hiking. You're going to start to loosen some of that clothing. Maybe strip them down into their underwear. Turn on the AC in the back. Help cool their body down. Okay, heat stroke. Move the patient out of the hot environment into the ambulance. Set air conditioning to maximum cooling. Remove the patient's clothing. Administer high flow oxygen and assist ventilations when needed. Cover the patient with wet towels or sheets for heat stroke. Aggressively fan the patient. Exclude other causes of altered mental status. Check blood glucose level if possible. Transport immediately to the hospital. Notify the hospital. Call for ALS if the patient begins to shiver. Drowning. Process of experiencing respiratory impairment from submersion or immersion in liquid. Some agencies may still use the term near drowning to refer to a patient who survives at least 24 hours after suffocation in the water. Risk factors. Alcohol consumption, pre-existing seizure disorders, geriatric patients with cardiovascular disease, unsupervised access to water, laryngospasm. Inhaling water causes muscles of larynx and vocal cords to spasm. Spinal injuries and submersion incidents. Submersion incidents may be complicated by spinal fractures, spinal cord injuries. Assume spinal injury if submersion resulted from a diving mishap or fall. The patient is unconscious. The patient complains of weakness, paralysis, or numbness. Most spinal injuries and diving incidents affect the cervical spine. Stabilize the suspected injury while the patient is still in the water. So remember, anytime you pull somebody out of the water, always suspect a spinal cord injury until you can clear it. If the patient's unconscious, go ahead and C-spine him. So safety. Water rescues are usually handled by specialized rescue personnel. Reach, throw, and row, and only then go. Okay, so you want to go from the least, the least way you're going to injure yourself to the worst way you might. So you want to reach for the patient, throw them something, probably attached to a rope to the patient if you can, or get in the water yourself. I would recommend waiting for specialized personnel to get in the water to save that person, especially if you're not trained. Recovery techniques. The patient is not floating or visible in the water. An organized rescue effort is necessary. Specialized personnel are required with snorkel, mask, and scuba gear. Resuscitation efforts. Never give up on resuscitating a cold water drowning victim. Hypothermia can protect vital organs from the lack of oxygen. So remember, the patient's not pronounced dead until they're warm and dead. So patients has been drowned, you're going to start CPR and you continue CPR. So, and remember also mammalian diving reflex I talked about earlier. It may cause immediate bradycardia, slowing of the heart rate caused by submersion in cold water. So, descent emergencies caused by the sudden increase in pressure as a person dives deeper into the water. Typical areas affected: lungs, sinus cavities, middle ear, teeth, and face. Pain forces the diver to return to the surface to equalize the pressures, and the problem clears up by itself. Perforated tympanic membrane. Cold water may enter the middle ear through a ruptured eardrum. The diver may lose his or her balance, shoot to the surface, and run into ascent problems. So I'm not sure if any of you guys have actually scuba dived before. They teach scuba divers to continuously breathe as they're either descending or ascending due to the pressure. It's caused their lungs to burst. So always be aware of these injuries when you're pulling a diver out. Emergencies at the bottom rarely occur, caused by faulty connections in the diving gear, inadequate mixing of oxygen and carbon dioxide in the air driver's breather. Accidental feeding of poisonous carbon monoxide into the breathing apparatus can cause drowning or rapid ascent. So ascent emergencies usually requires aggressive resuscitation, air embolism. Most dangerous and most common scuba diving emergency: bubbles of air in the blood vessels. Air pressure in the lungs remain at a high level while pressure on the chest decreases. Decompression sickness, or also known as the bends. Bubbles of gas, especially nitrogen, obstruct the blood vessels. Conditions that can cause the bends: too rapid an ascent from a dive, too long of a dive at a too deep of depth, repeated dives within a short period. Decompression sickness complications: blockage of tiny blood vessels, depriving parts of the body of their normal blood supply, severe pain in certain tissues or spaces. Signs and symptoms: abdominal joint pain so severe that the patient doubles up. You may find it difficult to distinguish between air embolism and decompression sickness. Air embolism generally occurs immediately on return to the surface. Symptoms of decompression sickness may not occur for several hours. Treatment is the same for both: basic life support, recompression in a hyperbaric chamber. So know which hospitals have hyperbaric chambers. Chomp obviously has one because they're right next to the water. So any diving emergency, you're probably going to try and transfer them over to Chomp to get them in that hyperbaric chamber unless it's a trauma. Scene size up, scene safety, gloves and eye protection. Never dive through moving water. Be cautious driving through still water. Never attempt a water rescue without proper training and equipment. Consider trauma and spinal mobilization. Check for additional patients. Primary assessment: form a general impression. Pay attention to chest pain, dyspnea, and complaints of sensory changes. Determine level of consciousness using the ABPU scale. Be suspicious of drug or alcohol use. Airway and breathing. Open the airway and assess breathing in unresponsive patients. Airway and breathing. Consider spinal trauma and take appropriate actions. Suction if the patient has vomited. Provide ventilations with a bag valve mask for inadequate breathing. If the patient is responsive, provide high flow oxygen with non-breathing mask. Auscultate and monitor breath sounds. Circulation: it may be difficult to find a pulse. If the pulse is unmeasurable, patient may be in cardiac arrest. Begin CPR and apply your AED. Evaluate for shock and perfusion. If the MOI suggests trauma, assess for bleeding and treat appropriately. Transport decision: always transport near drowning patients to the hospital. Inhalation of any amount of fluid can lead to delayed complications. Decompression sickness and air embolism must be treated in a recompression chamber. History taking: investigate the chief complaint. Obtain a medical history. Be alert for injury-specific signs and symptoms. Sample history. Determine the depth of the dive, length of the time the patient was underwater, time of onset of symptoms, and previous diving activity. Note any physical activity, alcohol or drug use, or other medical conditions. Secondary assessment: physical examinations. Examine lungs and breath sounds. Look for hidden life threats and trauma, indications of the bends or air embolism, and signs of hypothermia. Complete a detailed body scan en route to the hospital. Assess for peripheral pulses, skin color and discoloration, itching, pain, paresthesia, numbness and tingling. Vital signs: check pulse rate, quality and rhythm, check respiratory rate, quality and rhythm, and listen for lung sounds. Assess pupil size and reactivity, monitoring devices. Oxygen saturation readings may be inaccurate. So always treat your patient. Don't treat the monitor. Just because it says 100% on room air, on your SpO2, always treat the patient. How is the patient presenting? If the patient needs oxygen, give them oxygen. Reassessment, always repeating the primary assessment. Drowning patients may deteriorate rapidly due to pulmonary injury, fluid shifts in the body, cerebral hypoxia, hypothermia, pneumothorax, air embolism, or decompression sickness. Patient may decompensate quickly. Document circumstances of drowning and extrication, time submerged, temperature and clarity of the water, possible spinal injury. Bring a dive log or dive computer. Bring all dive equipment to the hospital. Emergency care for drowning or diving emergencies. Mobilize and protect the patient's spine if a fall or diving injury is possible. If the patient is not breathing, assist ventilation with a BVM or pocket mask. Do not roll the patient onto his or her side or perform abdominal thrusts. Provide chest compressions and use the AED if indicated. Treat for hypothermia. For air embolism or decompression sickness in a conscious patient, remove the patient from the water. Try to keep the patient calm. Administer oxygen. Consider the possibility of pneumothorax and monitor breath sounds. Provide prompt transport. Other water hazards. Pay close attention to the body temperature of a person who is rescued from cold water. Breath-holding syncope. A person swimming in shallow water may experience a loss of consciousness caused by a decreased stimulus for breathing. Treatment is the same as a drowning patient. Prevention. Appropriate precautions can prevent most immersion incidents. All pools should be surrounded by a fence. The most common problem in child drownings is a lack of adult supervision. Half of all teenage and adult drownings are associated with the use of alcohol. So high altitude dysbarism injuries caused by the difference between the surrounding atmospheric pressure and the total gas pressure in the body. Altitude illness caused by diminished oxygen in the air at high altitudes. So I'm sure you guys have all been up in the mountains. As you guys ascend further and further, higher up the mountain, the air gets a little thinner, it gets a little harder to breathe. This causes some people to get sick. It affects the central nervous system and pulmonary system. Acute mountain sickness, diminished oxygen in the blood caused by ascending too high, too fast, or not being acclimatized to high altitude. Signs and symptoms: headaches, lightheadedness, fatigue. Loss of appetite, nausea, difficulty sleeping, shortness of breath during physical exertion, swollen face. High altitude pulmonary edema or HAPE. Fluid collects in the lungs, hindering the passage of oxygen into the bloodstream. Signs and symptoms: shortness of breath, cough with pink sputum, cyanosis, rapid pulse. So remember, you guys asked PACE for respiratory questions. So what does the S stand for? It stands for sputum. So if they're coughing up pink sputum, they probably got fluid or rails in the lungs. So high altitude cerebral edema, HACE, may accompany HAPE and can quickly become life-threatening. Signs and symptoms: severe constant throbbing headache, ataxia, extreme fatigue, vomiting, loss of consciousness. Treatment of HAPE and or HACE: provide oxygen, descend from height, transport promptly. Provide positive pressure ventilation with a background mask for inadequate respirations. So lightning is the third most common cause of death from isolated environmental phenomenon. Targets of direct lightning strikes: people engaged in outdoor activities, boaters, swimmers, golfers, anyone in a large open area. Many individuals are indirectly struck when standing near an object that has been struck by lightning, such as a tree. The cardiovascular nervous systems are most commonly injured. Respiratory or cardiac arrest is the most common cause of lightning-related injuries, or lightning-related deaths. Categories of lightning injuries: mild, loss of consciousness, amnesia, confusion, tingling, superficial burns. Moderate, seizures, respiratory arrest, dysrhythmia, severe burns, severe cardiopulmonary arrest. So emergency medical care: protect yourself, move the patient to a sheltered area, use reverse triage. treatment, stabilize the spine, open the airway, assist ventilations, or use an AED, control bleeding, and transport. So with anybody struck by lightning that's unconscious, first thing we're going to do with any unconscious patients, open the airway, make sure they're breathing, make sure they have a pulse. Especially people that have been struck by lightning, they basically get a shot of electricity. It's basically they defib themselves through that lightning, and it could cause them to go into a lethal or deadly rhythm, and they might be in cardiac arrest when you get a call for something like this. So be on high alert for somebody who's been struck for lightning. You might have to have that AED ready to go. You're bringing that AED on every call, but this is a call you might have to use it on right away. Spider bites. Spiders are numerous and widespread in the United States. Many species of spiders bite. Only the female black widow spider and the brown recluse spider deliver serious or life-threatening bites. Be alert to the possibility that the spider may still be in the area. Black widow spider. The female is fairly large, measuring approximately 2 inches across, usually black with a distinctive bright red-orange marking in the shape of an hourglass on its abdomen. Found in every state except Alaska. Prefer dry, dim places. The bite is sometimes overlooked. Most bites cause localized pain, and symptoms include agonizing muscle spasms. The main danger is the venom, which is poisonous to nerve tissues. Other systemic symptoms include dizziness, sweating, nausea, vomiting, rashes, tightness in the chest, severe cramps. Generally, these symptoms subside over 48 hours. Emergency treatment consists of BLS for the patient in respiratory distress, transport as soon as possible. Brown recluse spider, dull brown in color and 1 inch long, violin-shaped mark on its back, lives mostly in the southern and central parts of the country. Tends to live in dark areas. The venom is not neurotoxic but cytotoxic. It causes severe local tissue damage. Typically, the bite is not painful at first, but becomes so within hours. The area becomes swollen and tender, developing a pale, mottled cyanotic center. So bees, wasps, yellow jackets, ants. Stings are painful but are not medical emergency. They remove the stinger and venom sac using a firm-edged item such as a credit card to scrape the stinger and sac off the skin. Anaphylaxis may occur if the patient is allergic to the venom. Snake bites. Of the approximately 115 different species of snakes in the United States, only 19 are venomous. Rattlesnake, copperhead, cottonmouth, or water moccasins, and coral snakes. So here's your different types of venomous snakes. You have your rattlesnake up here. I think this might be your copperhead, and then your cottonmouth right here. So snakes usually do not bite unless provoked, angered, or accidentally injured. Protect yourself from getting bit. Use extreme caution and wear proper PPE. The classic appearance of the poisonous snake bite is 2 small puncture wounds with discoloration, swelling, and pain. So pit vipers. Rattlesnakes, copperheads, and cottonmouths are all pit vipers, with triangular-shaped flat heads. Small pits that contain poison located just behind each nostril and in front of each eye. So this is your picture of a pit viper and its 2 fangs. Your venom sac is going to be back here. So rattlesnakes, most common form of pit viper, many patterns of color, diamond pattern, can grow to 6 feet or longer. Copperheads usually 2 to 3 feet in length, red copper color crossed with brown and red bands. Their bites are almost never fatal, but the venom can cause significant damage to extremities. Cottonmouths, olive or brown with black cross bands and a yellow undersurface. Water snakes with aggressive behavior, tissue destruction may be severe. Signs of envenomation: severe burning pain at the site of injury, swelling and bluish discoloration, weakness, nausea and vomiting, sweating, seizures, and fainting. Vision problems, changes in level of consciousness, shock. Treatment. Calm the patient and place in a supine position. Locate the bite area and clean it gently with soap and water. Be alert for an anaphylactic reaction and treat with an epinephrine auto-injector as appropriate. Do not give anything by mouth. Be alert for vomiting. If the bite occurred on the trunk, keep the patient supine and quiet and transport as quickly as possible. If there are any signs of shock, treat for it. If the snake has been killed, bring it with you. Notify the hospital that you're bringing a patient with a snake bite. Transport promptly. So you want to notify the hospital as soon as possible and then let them know what kind of snake it is, if possible, so they can start getting that venom or that antidote ready to give to the patient. Coral snake, small reptile with a series of bright red, yellow, and black bands completely encircling the body. Lives in most southern states. Injects the venom with its teeth and tiny fangs by chewing motion, leaving puncture wounds. Usually bites victims on a finger or toe. Coral snake venom is a powerful toxin that causes paralysis on the nervous system. Within a few hours of being bit, a patient will exhibit bizarre behavior, followed by progressive paralysis of eye movements and respirations. Anti-venom is available, but most hospitals do not stock it. Emergency care is the same as for a pit viper bite. Scorpion stings. Scorpions are 8-legged arachnids with a venom gland and a stinger at the end of their tail. They are rare and live primarily in the southwestern United States and in deserts. With one exception, a scorpion sting is usually very painful but not dangerous. Okay. I'm sure you guys have at least seen a picture of a scorpion. An exception is the centroids sculpturatus. The venom may cause circulatory collapse, severe muscle contractions, excessive salivation, hypertension, convulsions, and cardiac failure. Tick bites. Tiny insects that usually attach themselves directly to the skin, found most often in brush, shrubs, trees, sand dunes, or other animals. Only a fraction of an inch long. Danger comes from infectious diseases spread through the tick's saliva. So it's a pretty small tick, and then this is the aftermath of his bite. Rocky Mountain spotted fever occurs within 7 to 10 days after the bite. Symptoms: nausea, vomiting, headache, weakness, paralysis, cardiorespiratory collapse. Lyme disease reported in all states except Hawaii. The first symptoms are generally fever and flu-like symptoms, sometimes associated with a bullseye rash that may spread to several parts of the body. Painful swelling of the joints occurs, may be confused with rheumatoid arthritis. Tick bites occur most commonly during the summer months. If transport will be delayed, remove the tick by using fine tweezers to grasp the head and pull it straight out of the skin. So make sure you're pulling the head out. Don't pull by the body because it's going to leave the head in and it's still going to cause problems. Once the tick is removed, clean the area with antiseptic and save the tick for an identification. This way the hospital could look at it and decide how they're going to treat. Injuries from marine animals. Coleonterates are responsible for more envenomations than any other marine animals. Fire coral, Portuguese man-o'-war, sea wasp, sea nettles, true jellyfish, sea anemones, true coral, and soft coral. So here's your jellyfish right here. Signs and symptoms: very painful reddish lesions in light-skinned individuals, headache and dizziness, muscle cramps, fainting. Emergency treatment: limit further discharge of nematocysts by avoiding fresh water, wet sand, showers, or careless manipulation of the tentacles. Keep the patient calm, reduce motion of the affected extremity, remove the remaining tentacles by scraping them off with the edge of a sharp, stiff object. Provide transport to the emergency department. Okay. So when a person is exposed to cold temperatures and strong winds for an extended period of time, he or she will lose heat mostly by what? So B, convection occurs when heat is transferred to circulating air, as when cool air moves across the body's surface. A person wearing lightweight clothing and standing outside in cold, windy weather is losing heat to the environment, mostly by convection. So shivering in the presence of hypothermia indicates that the So C, shivering in the presence of hypothermia indicates that the body is trying to generate more heat, thermogenesis, through muscular activity. In early hypothermia, shivering is a voluntary attempt to produce heat. As hypothermia progresses, shivering becomes involuntary. All the following are examples of passive rewarming techniques except So B, passive rewarming involves allowing the patient's body temperature to rise gradually and naturally. Removing cold, wet clothing, turning up the heat in the ambulance, and covering the patient with warm blankets are examples of passive rewarming. Administering warm fluids by mouth or intravenously is an example of active rewarming. This should be avoided in the uncontrolled pre-hospital setting. So a woman has frostbite in both feet after walking several miles in a frozen field. Her feet are white, hard, and cold to the touch. Treatment at the scene should include what? Sure you guys already saw it. So D, when treating a patient with frostbite, you should remove any wet clothing and cover the injured area with dry, sterile dressings. Do not break any blisters and do not apply heat to rewarm the area. So remember, you're not going to rub her feet. That's going to force cold venous blood back up to the heart. You're not going to allow a person to walk around or stand on a frostbite frozen foot. And you're not going to apply something warm or hot to her extremity as well. So a 30-year-old male has been playing softball all day in a hot environment, complains of weakness and nausea shortly after experiencing a syncopal episode. Appropriate treatment for this patient includes all the following except So A, treatment for heat exhaustion begins by moving the patient to a cooler environment. Remove excess clothing, administer oxygen as needed, and place the patient supine. Elevating the patient's legs may improve blood flow to the brain and prevent another syncopal episode. If the patient is not nauseated, give a salt-containing solution by mouth. Give nothing by mouth if the patient is nauseated. Doing so increases the risk of vomiting and aspiration. So you're assessing a 27-year-old woman with a heat-related emergency. Her skin is flushed, hot, and moist, and her level of consciousness is decreased. After moving her to a cool environment, managing her airway, and administering oxygen, you should So C, the patient experienced heat stroke. After moving her to a cooler area, managing her airway, and administering oxygen, single most important treatment for her involves rapid cooling. Turn on the AC in the back of the ambulance, cover her with a wet sheet, and begin fanning her. Consider applying chemical ice packs to her groin axilla. Follow your local protocols. Untreated heat stroke almost always results in death due to brain damage. It is important to remove a drowning victim from the water before laryngospasm relaxes because
So C, even small amounts of salt or fresh water will irritate the larynx, causing it to spasm. Laryngospasm, this is the body's protective mechanism. The EMT can safely remove the patient from the water before the laryngospasm relaxes. The amount of air that enters the lungs will be minimized. It will also be easier to ventilate the patient. So 13-year-old girl is found floating face down in a swimming pool. Witnesses tell you that the girl had been practicing diving. After you and your partner safely enter the water, you should. Remember, anybody who's been in the water that's unconscious, always assume the worst. Always assume a spinal cord injury. When caring for a patient who is in the water and has possibly been injured, rotate the upper half of the body as a unit, supporting the head and neck until the patient is face up. Open the airway with the jaw thrust maneuver and begin artificial ventilation. So shortly after ascending rapidly to the surface of the water while holding his breath, a 29-year-old diver begins coughing up pink, frothy sputum and complains of dyspnea and chest pain. You should suspect and treat this patient for... What does pink, frothy sputum indicate? So A, signs of an air embolism, which present after a person rapidly ascends to the surface of the water while holding his or her breath, including skin mottling, pink froth at the mouth or nose, muscle or joint pain, dyspnea and or chest pain, dizziness, nausea or vomiting, visual impairment, paralysis or coma, and even cardiac arrest. 3 ambulances respond to a golf course where a group of 6 golfers were struck by lightning. 2 of the golfers are conscious and alert with superficial skin burns. The next 2 golfers have minor fractures and appear confused. The last 2 golfers are in cardiac arrest. According to reverse triage, which group of golfers should be treated first? So C, the process of triaging multiple patients who are struck by lightning differs from the standard triage. It is called the reverse triage. If the patients are still alive at the scene, survival is likely. Delayed cardiac arrest following a lightning strike is uncommon. If the patients are in cardiac arrest, there is a good chance that they can be resuscitated with early, high-quality CPR and defibrillation. Therefore, Group 3 should be treated first.